Hello everyone. I'm very happy, honored and thankful having been invited to this very special event. First, let's have a look at what scoliosis really is. It's a three-dimensional deformity of the spine and trunk, including a rib hump indicating a rotation, a frontal plane deviation, and a disturbance of the sagittal profile, namely a flat back in this case, as can be seen on the right. Most of the scoliosis conditions are adolescent idiopathic, we call AIS in short. But there are also more rare conditions like neuromuscular, congenital, and many others. Here on the left we have a patient with spina bifida occulta, a patient with neurofibromatosis, and a patient with arthrogryposis multiplex congenita AMC on the right. Today we do know that progressive idiopathic scoliosis is based on a functional tethering of the spinal cord. An impingement of the spinal cord in the spinal canal, which initiates the growth disturbance. The basic modules of treatment are physical rehabilitation, brace treatment, and surgery. Still today, no evidence for spinal surgery has been established in patients with spinal deformities, a fact supporting the conclusion that there is no indication for this kind of treatment. On the other hand, surgery seems to have a high rate of long-term complications. This has been found by Hans in 2006 and later by our working group as well. In a more recent review from our working group, a paper on the CD instrumentation was found with a reoperation rate of 48% within 5 to 20 years. Therefore, within this presentation we will focus on the less risky and more evidence-based conservative approaches. Let's have a look at the first module, which is physical medicine and rehabilitation. Let's start with the original Schroth program, which was basically designed for one curve pattern only with individual modifications. The principle of correction was static overcorrection, which means a shift to the thoracic concave side with additional elongation. These are two original manuscripts by Katharina Schroth. And she explains the difference between bending and shifting with additional elongation. In practice, it looked like shown on this picture. Most of the patients with a static overcorrection to the left and elongating by lifting themselves up on their arms from their pelvis. Mainly huge thoracic curves have been treated by Katharina Schroth, be it right or left thoracic. These major thoracic curves today are called free curve patterns. As these huge curvatures, usually exceeding 70 degrees, appear like being of kyphotic shape in the lateral view, Katharina Schroth corrected these curves in a sagittal plane by uprightening the thoracic kyphosis. In the 40s, her daughter Christa Schroth started to help in the little institute. Notice that patients monitor their correction with the help of mirrors. Some pictures from the 20s, 30s and the beginning of the 40s, also with Christa Schroth in charge of treating patients. In the 50s, Katharina Schroth and her daughter moved to the west part of Germany. And both ladies later opened a new center in Sobernheim in the beginning of the 60s. Here we have some documentation of the original Schroth program within the first Schroth film with Katharina Schroth and her daughter Christa, Weiss, from the year 1959. Now we come to the intermediate Schroth program, which is based on a little classification, distinguishing between 3 and 4 curve patterns. The basic principle was a correction to the midline. In 1979, Christa Lena Schroth discovered that lumbar curvatures would not correct sufficiently with the original Schroth program, and she developed exercises for the treatment of this kind of curve pattern. She called the 4 curve pattern, or C. This was the start of what today we call the intermediate Schroth program. In the 3 curve patterns we have a shoulder block, a thoracic block and a lumbopelvic block rotated and deviated against each other, while in the 4 Cs the lumbopelvic block is divided into a lumbar block and a pelvic block rotated and deviated against each other. This little classification we call the Lena-Schroth classification has been validated in the year 2020. Here we find some documentation within some film sequences from the 80s of the last century. In 2007, the 7th edition of Christa's book appeared and was also published in English language. Still, the sagittal corrections from the original Schroth program were promoted, like also applied for the treatment of poor posture and thoracic kyphosis. In 1995, the Katharina Schroth Clinic was taken over by Asklepios, and the intermediate program, including many exercises in supine or prone position, was continued using a lot of technical aids. The sagittal corrections were still antikyphotic, which increased the flat back typical for medium and small thoracic curvatures, as can be seen here. The Schroth program became more and more complex due to the addition of a large number of rules and tools, and no longer easily comprehensible for the patients. The increasing number of exercises by lying down diluted the effectiveness, as these barely address the autochthonous core muscles. The one-sided student-teacher setting was usually very tiring for the patients and did not contribute to internalizing the postural control. The original sagittal corrections proved unsatisfactory for the majority of curvatures. Indeed, the original sagittal plane corrections were a dead end for moderate idiopathic and degenerative curves, as these usually present with a lumbar kyphosis and a thoracic flat back. Today, the intermediate Schroth program still survives in the Bad Sobernheim School of Scoliosis Treatment, ISST, as well as in the Barcelona School. The recent development is the Schroth Best Practice Program, we simply call SBP. Mirroring of the deformity is the basic correction principle within SBP. The recent development has led to a simplification by implementing the most effective exercises with more corrections and updated approaches to the patient. By the use of correction exercises in upright position only, implementing experiential learning, and implementing physiologic corrections in a sagittal plane. The SPP corrections focus on the 7 basic curve patterns of the ALS classification and on 6 modules of treatment. This classification has been validated recently. The first module is called Physiologic, which aims at a correction of the sagittal deviation. While the physiologic exercises are correcting the sagittal plane only, the ADLs, the second SPP module, correct in frontal plane mainly. The third SPP module is 3D Made Easy, the first step to 3D correction. Within this learned, it is easy for the patient to acquire the skills necessary for the performance of the Schroth program later on. The fourth SPP module is Schroth. As can be seen, the program aims at an overcorrection, at a mirroring of the deformity. The sagittal correction with lumbar lordization and thoracic kyphosation is visible as well. Here we have a 4C correction with both curves mirrored. This is better visible when the picture is rotated. Initially we have a right thoracic in the left lumbar curve, and in the exercise, as you can see, we have a left thoracic and a right lumbar curve. Now we come to the original Schroth part of the SPP program for thoracic curves exceeding 60 to 70 degrees. The original Schroth program was developed for curves like this. Here we have the twisted seat exercise with all 5 pelvic corrections implemented. Together with my mother, Kristalina Schroth, we were treating this 3C patient with more than 100 degrees in the thoracic area. The 5th SPP module is the rehabilitation of walk, where we can implement the sagittal corrections from the physiologic program as well as the shoulder girdle corrections from the 3D made easy. Finally, the 6th SPP module are the tethering exercises. The background of these exercises is the evidence that in AIS a functional tethering of the spinal cord has been found. Some of these exercises can also be performed at the workplace. Here we have a synopsis of the development of the Schroth program throughout the last century, from the original Schroth program via the intermediate program to the SPP program on the top. This paper so far is the only randomized controlled trial with an untreated control group and was performed by our friend Koob from Istanbul, Turkey. There is quite a number of studies, mainly in the pre-post design, demonstrating that the old-style intensive rehabilitation program from the 90s has some effects on many signs and symptoms of scoliosis. Nearly all signs and symptoms of scoliosis can be beneficially influenced when using Schroth. This also has been confirmed when applying SPP in more recent papers by Lee, Pukacheva and Borisov. Here is the first prospective controlled study in English language, demonstrating that Schroth is superior to observation when done in a clinical environment. However, the sample investigated was of patients treated between 1989 and 1991. For the actual inpatient program in Germany, there is no evidence, as this has been changed by the time. A new intensive short-term rehabilitation program has been elaborated with a specific design allowing the patients to acquire the necessary skills in a relaxant and pleasant environment, but also promoting the exchange of experience among themselves. Now let's have a look at brace treatment. The Milwaukee brace formerly was applied for patients with scoliosis, and this kind of bracing has a long history. The Lyonnaise brace, developed by Pierre Stagnara and his orthotists, also has a long history starting from 1947. The Boston brace today still is used in many countries worldwide. These are symmetric compression braces without any visible corrective movement derived from the Stagnara or Lyonnaise approach. The Chengdu brace is an asymmetric pattern-specific brace providing a corrective movement. Here we have Dr. Chengdu doing one of our brace courses provided by myself in the 90s in Bad Sobernheim. This book is a document of my collaboration with Dr. Chengdu and Dr. Rigo. Not all braces will be able to be comfortable and highly corrective. Many different braces are on the market today, but not all are really helpful. There is evidence that the outcome of brace treatment varies to a high extent, also for Chengdu-style derivatives, and I would like to show you why. On the right you see an outdated Chengdu-style brace from the year 2016, without shift and without recompensation of the shoulder girdle, compared to a Genzinger brace, GBW, with a clear mirroring of the right thoracic curve on the left. Both braces are made for a right thoracic curve. Here we have a printed Chengdu-style brace from 2022 without any visible corrections, as the superimposed images on the right show, and with misplacement of the pads. Here you can see a Genzinger brace from 2016, and the corrective movement is clearly documented. The deformity is mirrored in the brace, and the vast corrective movement is documented on the right-hand picture with a vast shift of volumes as indicated by the arrows. Meanwhile, there is a randomized controlled trial on bracing. Therefore, bracing is evidence-based on the highest level. This is the Bracing for Adults with Idiopathic Scoliosis trial, simply called BRACED. The overview on the variability of the success rates, as documented within this paper, demonstrates the need for improvement of bracing standards in order to secure patient safety in bracing during growth. This is the recent paper on the results of the Genzinger brace from my former center in Genzing. When considering the definition of success as in the braced, a curve not reaching or exceeding 50 degrees, the success rate in this sample respecting the SRS inclusion criteria was 96% versus 72% only in the braced. Independent studies on soft bracing have shown that this kind of application has no advantage over observation only. Here we have a final result after bracing with a nice cosmetic effect and with a balanced appearance. This is a result after treatment with the Gensingen brace. This also is a result after brace weaning. A patient from New Zealand having had 2 braces in my office, just to show that all the clinical improvements can be achieved. The final result in this girl from Turkey was 15 degrees, with a nice cosmetic appearance compared to the initial findings. A patient from Norway, 2 years after brace weaning, representing Scandinavia in modeling at the World Competition of Performing Arts 2019, and she was winner in the category Everyday's Model. The Gensingen brace incorporates all principles of correction as in the Schroth best practice program. But what you can see here is not an exercise we usually perform. Now let's have a short glance on scoliosis and pain, or scoliosis and the aging spine. Patients with chronic low back pain can clinically be subdivided into 2 different groups: postural back pain and instability back pain, by using these simple tests. Postural low back pain can be treated by restoring the physiologic sagittal profile. This patient with chronic low back pain had physiologic exercises only for 3 months, and now she is pain-free. When a positive sagittal realignment test will immediately reduce low back pain, physiologic exercises or the physiologic brace will be indicated, which sometimes also improves ambulation, as can be seen on the right. This patient with a spondylolisthesis and instability low back pain had instant pain relief from bracing with the spondylogic brace. Chronic back pain in scoliosis patients can also be treated with Schroth exercises and a pattern-specific Gensingen brace worn part-time. The actual state-of-the-art approaches and the evidence for the management of the spinal deformities is presented in this textbook, edited by members of the SPP Academy. Finally, I would like to have a look at useful add-ons. Manual therapy and chiropractic are used to treat pain, especially when the dysfunction or blockages prevent corrective exercises or the brace application. There is, however, no scientific evidence that this method could stop curve progression of a scoliosis in the growing age. Detethering exercises and extracorporeal shockwave therapy can also be applied. Since the effect of shockwave therapy has been shown to be short-lived, we have developed a special exercise program to promote spinal cord mobility, largely derived from an advanced Qigong protocol. This treatment module today is part of the Schroth Best Practice program. The use of acupuncture and Chinese herbal medicine is rarely mentioned in the literature on scoliosis treatment. I myself conducted a controlled pilot study in which it was clearly demonstrated that proper acupuncture compared to sham acupuncture resulted in significant improvement of postural asymmetry as measured by the metric surface topography system. Of course, the already described successful therapy modules, such as the Schroth Best Practice program and/or the Gensing embrace, must not be replaced by these methods. However, it could be investigated in controlled studies whether at all or to what extent traditional Chinese medicine as an add-on would prove to be beneficial and helpful. I would like to conclude my lecture with the results of a patient from China, treated by my friend Naxin Fong, with a thoracolumbar curve exceeding 40 degrees. The treatment consisted of a Gensing and short brace and of the application of the Schroth Best Practice physiotherapy. Note the pelvic prominence on the right. A nice in-brace correction has been achieved, shifting the pelvis over to the left. And the final result is quite remarkable, with a nice recompensation of the pelvis and with a vast reduction of the thoracolumbar hump. Thank you for watching my video lecture. I wish you a pleasant conference ahead.